So premolar 5.5 into 10 basal and one implant in the molar. This is the molar cross section. See the butters here. This is the butters, zygomatic butters. When you want to give LA, the buccal sulcus, you will feel some elevation in the 6 area. To be exact, it is the distal root of 6 area. Okay. This goes as a zygoma. Okay. This is the reason why your S6 extraction becomes difficult, because this butters comes till 6. That is why 6, when you extract, it is not at all moving, you are feeling strong. 3 roots, that is also one reason, but this is also one of the reasons. Okay. So the sinus floor is not very great. The sinus membrane is quite thick. The crestal bone 0. There is no evidence of any white line. The entire ghost. Okay. So even if you place implant, it will be very little stability only. Maybe 20 Newton, something like that. But if you do welding, it will. Even here, you have the option to go here. Because the compressive implant, the apical of it is thin. You can place it here. Just discussion. So the final plan is 4.2, 20 here, 5.5, 10 here, 4.2. What is the length? Into 8. 8 mm implant will be placed.
Over in such cases, bending like
you cannot bend.
Like fraction,
The bone only will move. The implant will move, it won't bend. The bending means the neck should bend. Here the implant itself will fully move. If you move this, it will go that side, it will move that side.
Like you said, here on the palatal side, we can take an angulated one, and in that case, we place angulated.
You will get stability, you will bend.
We need not.
You can bend. Because the bone there is good. You will get good stability. Bending is allowed only if you get good stability.
Okay.
Less stability means you cannot bend. Here there is no need for bending.
Okay.
The abutment will come in the right position.
We can place in a straight line axis rather than going to
avoid
bending. To avoid bending, but which is the best? Like we have to follow the anatomy of the thing, or
so we are going straight, right? Fix the abutment and we will see. So it comes in the correct position now. There is no need for any bending. Even if you want to bend, if there is any need for bending, you can bend because you are placing a long implant. No issues. Now we are planning for the left side. Left side, actually the patient doesn't want to get the 8 more. So what we suggested the plan is go for 2 implants without loading. We won't give the tooth now. After 3 months we will give the tooth now. If you remove the 8, we will place a good implant in the pterygoid bone. So immediate loading is possible. Already there is sinus has come down, the bone quality is very poor. So whenever the bone quality you see in the CBCT, so you have to send the patient for vitamin D test. Whenever you see, so by seeing OPG you can tell this patient is a vitamin D deficient patient. Almost with 99% accuracy we can tell. Okay. So definitely it will be below 10 something. It should be above 30, right? But most of the time it will be below 10, even 6, something like that. So vitamin D test, whenever you are writing vitamin D test, you have to write one more thing, HDL, LDL. Whenever vitamin D is in trouble, HDL, LDL also will be in trouble. The cholesterol will be higher. When the cholesterol fat is more, it actually replaces the bone, replaces the calcium mineral inside the bone. The more fat deposition happens, it reduces. So whatever the black thing is, it is not bone, but what it is a fat.
So what is the second one?
HDL, LDL. So during drilling itself, you will see shiny liquid coming out from there. If you open, you will see yellow bone. That is fat. During drilling, something like oil, it will come, the fat. So we will plan here only 2 implants. The bone is here only 7 mm, but we can place a 7 mm, but we can place 8 mm. The implant will lift the sinus membrane. Even if it is perforating, no issues. 4.2 into 8. And one more implant.
What happens suppose we perforate, sir?
Nothing left. So it is in the middle. Here the bone is very less. However, we are planning for only 2 implants. So what we will do is we will go in slightly distally, just in front of the 8. Here the bone is good. 4.2 10 we can place. Okay. So here our plan is 4.2 into 8, 4.2 into 10. So if there is no symmetry, what we will do, you will take IOP or panoramic view and you do the drilling and you will find it out. The length. Diameter, you will open the flap and you will find it out. Or you palpate the ridge. Okay. Now we are not going to open the flap. 4.8, 4.2 10. Here 4.20, 5.5 10 or 12. 4 into 4.2 into 8. This is the plan for the maxilla. Okay. Now we will plan the see the axial section. The entire bone is black. That means all the mineral content has been displaced by fat deposition. So whenever you see a measly migrated 7, 6 is missing. That is good or bad?
I don't think it's good.
No? That is actually good. Your implant will be successful because the mesodistal space becomes less. Less occlusal forces. It will easily osseointegrate. The only difficulty you have to foot impaction. Okay. So whenever easily migrated for beginners, that is it.
Many cases come like this one.
Yeah, I
Yes,
thought that.
very easily you can manage.
Because it should be gone.
Okay. Just take the implant carrier and put it here in the patient mouth. If it goes, you can place the implant. That is the test. Take the implant carrier and place it here. If it goes, you can place the implant. If it is not going, just reduce still here. If it is too much easily migrated, then you cannot do it. So
And even if it is a molar space, you can place a small.
small premolar. Actually, your premolar, this prosthetic crown, no, it hides. These two people only will take all the load. They will nicely integrate. No failure will happen in this kind of cases. But here the situation looks very challenging. See, the bone is again a ghost kind of thing, ready loosened. Okay. So in this kind of very cancerous bone, you can see what is the, it's only 80, 49 something, no? So in this kind of situations, what I try to do is, I employ a small technique. I am giving a small distal tilt to the implant. See, instead of placing straight, distal tilt and try to engage the myloid ridge. The myloid ridge is present only distally. However, we are going to place implant in the molar. So I tilt the implant distally, I try to engage the myloid ridge. Or sometimes what I do is place the implant to delay loading. Tell the patient don't poke the implant with tongue or finger. After 2 months we can wait to take the risk. So even with single piece you can do delayed loading. Place the implant, do welding for single, only one implant, leave it. Tell the patient to wait for 2 months, then you can do. If you have too much doubt, then place conventional implant and do delayed loading. Okay. So when I tilt distally and go along the lingual wall. See, even I am keeping the mouse, the lingual cortical plate, even it is only 426, it is not 1000. So even the lingual plate, there is no mineralization. So highly osteoporotic person. So the length comes around 16. But the problem with tilting distal is the abutment will come mesially. You have to bend. Already the bone is anyhow we have to take this risk. You will see, this is a challenging situation. So this entire part is dark.
Patient is not willing for extraction of.
You said that to
Eight,
place 2
eight.
implants for molars.
Huh?
2 implants for molars.
Okay. Which one?
Generally, we can one implant.
Yeah, then if it is an extraction and implant molar,
Okay.
to place 2 implants. If it is already extracted, measure the mesodistal width. If it is 10 mm, 11 mm, 1 implant is enough. If it is 12, 13, 14, place 2 implant. This is the standard rule, atypical rule.
But
Even
if we extract and place immediately, we should always place.
always 2 implant.
Extraction always to implant.
Always
throughout
2
the
implant, 2
molar.
implant. Otherwise, what I do is extraction, place only 1 implant and do delay loading. The patient is not willing for 2 implants.
Okay, one implant,
Place 1
delayed
implant
loading.
and do delay
Delayed
loading.
loading is 2 implants.
2 implants for molars, for lower molars.
Follow the socket.
Yes,
No.
mesial root 1, distal root 1.
Sir, 2 implants na
And
Mesial
how
root,
about
distal root 1. So we'll see the first this thing. As usual, as we planned, it went slightly mesially. Okay. Okay. Naturally it happens. That mesial tilting naturally it happens. Even if you want to avoid this mesial tilting, it happens. I don't know. So this is a basal 5.5 basal. This is 4.8. Even still more, we can go deeper. Even we could have selected a 4.2 to 10. It might have elevated the sinus flow. So this is 4.28. Good stability here we got. Even though it is a small bone, but the bone quality here is good compared to the other area. This is 4.2 to 10 as we planned. Okay. Even some more, 1 or 2 turns we can do.
One was very tough to work with. One thing you had good resistance, crushed it.
The mesial one. Yes, the mesial one. Maybe because the crestal bone is thick. Other areas the crestal bone is very porous, so the implant went inside. But here, the implant didn't went inside because we widened the crestal bone with parallel. This we planned 2 plants in the lower molar, either straight or slightly tilted lingual cortical. It came good. So what I thought was, the stability is not great, even after getting lingual stability is not great. So better to delay the loading. So and tell them to take a vitamin D and HT result. Once they get the result, they also will understand, okay, they don't told. Actually these things we should do before. The delay loading should be done before. Vitamin D should be before. But we didn't see the X-ray at all. Okay. So the treatment planning stage itself, no, lot of problems and complications we can face. In case if the patient is fighting, you told the immediate loading if you are giving to it, then it will lead to problem. If you beginning itself, if you tell no, clear cut it is a delay loading. Or we tell as an open option. The bone is quite soft. During surgery, we will decide the bone is soft, it will go for delayed loading. That is a better option for us, everybody.
Actually, you can see the distance between the implant and the canal.
Yes. So this is the canning tip. Okay. It is not close.
At the next.
Even at the base. Yes. It is almost till the nasal floor it has went. Right? After that it is a nose. Nasal septum. See, only the left sinus is inflamed. Can you see?